Chapter 63 Chronic Neurologic Problems. We'll start with a headache, probably the most common type of pain experienced by people. And most people have functional headaches, meaning either migraine headaches or tension type headaches. Headaches can be classified two ways either as primary headaches that are not caused by a disease or another medical condition, such as tension type, migraine, or cluster headaches, or there's secondary headaches. These are caused by another condition, such as a sinus infection, neck injury, or brain tumor. In the case of tension type headaches, such as a stress headache, this is the most common form. Tension type headaches are characterized by a bilateral location and a pressing, tightening quality. It's usually of mild or moderate intensity and could either be episodic or chronic. On the other hand, there's migraine headaches. These are usually recurring and result with unilateral throbbing pain. They usually have triggers or early symptoms. The onset age is between 25 to 55 years, and they affect 12% of the population. When it comes to ATI or NCLEX, your first go to treatment is going to be resting in a dark, quiet room to relieve symptoms. There are many risk factors for a migraine headache, including family history, age, gender, obesity, depression, stress, and could also be defined in two categories without aura or a common migraine, or with an aura or a classic migraine. Another thing to keep in mind of for ATI and NCLEX is that the patient should take their migraine medication as soon as the onset of symptoms begin or when they get that premonition. In many cases, they will know when a migraine is coming, and they should take it as early as possible. Also, keep in mind, especially with Imitrex, that it's contraindicated with a previous MI. Because how is Imitrex working? It's a vasoconstrictor to lower the pressure within the brain. But unfortunately, that's also going to be constricting those coronary arteries as well. A cluster headache is the most severe primary headache, and it results from repeated headaches that generally occur at the same time of day or night. The onset age is between 20 and 50 years, and they tend to affect men more often than women. For this case, we're going to provide O2 to help reduce the symptoms of an acute cluster headache. And here at the bottom, we just have a diagram showing generally the body parts affected by our different forms of headache. Attention type headaches across the forehead, whereas a migraine has that unilateral pain we talked about, and a cluster headache located behind the eye. They can also be a symptom of serious illness, such as a subarachnoid hemorrhage, brain tumors, other intracranial masses, vascular abnormalities, trigeminal neuralgia, diseases of the eyes, nose, and teeth, and other systemic illnesses. For our specific health history, we want to look at things like the location and the type of the pain, as well as its onset, frequency, duration, and relation to outside events, looking for specific triggers. Moving on, let's talk about seizures. Seizures are a transient, uncontrolled electrical discharge of neurons in the brain that results in interrupting its normal function. They may accompany other disorders or occur without any apparent cause. Seizures from systemic and metabolic problems are not considered seizure disorder, even if they stop when the underlying condition is corrected. Clinical manifestations of seizures are determined by the site of the electrical disturbance, and they have three major classes: generalized onset, focal onset, or unknown onset. Remember, for us as nurses, make sure we're documenting all characteristics, including the onset of both the active and postictal states. Also, your priority is going to be to protect the patient from injury. Help to lower them from the floor. Lower them to the floor. Don't let them fall. Place them on the left side and loosen any restrictive clothing. Seizures may occur in multiple phases: the prodromal phase, or a sensation of impending seizure; the oral phase, such as seeing auras right before its onset; the ictal phase, where the patient is actively seizing; and the postictal phase, or recovery. Again, protect the patient from injury, and keep in mind to never put anything in the patient's mouth. That was an old wives' tale of needing to protect the air to stop them from swallowing their tongue. That is false. Never put anything in their mouth. In the case of tonic-clonic seizures, these are characterized by a loss of consciousness and falling to the ground. The body stiffens, such as tonic, with subsequent jerking of the extremities, clonic. Cyanosis, excessive salivation, and tongue or cheek biting may also occur. In the case of generalized onset non motor seizures, or your typical absence seizure, this usually only occurs in children and rarely beyond adolescence. It may stop as the child matures or may evolve into another type. It's characterized by a brief staring spell that typically lasts less than 10 seconds. An atypical absence seizure is characterized by a staring spell with other manifestations, such as eye blinking, jerking movements of the lips, lasting more than 10 seconds and usually continued into adulthood. In the case of a myoclonic seizure, this is characterized by a rhythmic arm abduction, such as 3 movements per second, leading to progressive arm elevation. It usually lasts 10 to 60 seconds and also may include eyelid myoclonia, which refers to the jerking of the eyelids. Focal onset seizures, formerly called partial or partial focal seizures, begin in specific regions of the cortex in one hemisphere of the brain, and they produce manifestations based on the functional area of the brain involved. Focal awareness seizures, the patient remains conscious and alert, and have unusual feelings or sensations that can take many forms, such as sudden and unexplainable feelings of joy, anger, sadness, or nausea. They may also hear, smell, taste, see, or feel things that are not real. Status epilepticus. This is a state of continuous seizure activity or a condition when seizures recur in rapid succession without return to consciousness between seizures. Any seizure lasting longer than 5 minutes is a neurologic emergency, and this can occur with any type of seizure. Seizures can unfortunately have a dramatic effect on the lifestyle and is the most common complication of seizure disorders, resulting in things like depression, social stigma, discrimination in employment and educational activities, and even driving sanctions. The primary drugs for the treatment of generalized tonic-clonic and focal onset seizures are the anticonvulsants we've spoken a lot both here and especially in mental health this term. We're talking about drugs like Dilantin, Tegretol, and Depakote. And keep in mind, once a patient is on an anticonvulsant, they're usually going to be on it for life, as stopping abruptly especially will increase the seizure frequency and intensity. Drugs used most often to treat the generalized onset non-motor and myoclonic seizures are things like Serotonin and Klonopins. Other drugs that may be used include things like Lyrica. This is an additional treatment for focal aware or impaired awareness seizures that are not successfully controlled with one medication. In the case of status epilepticus, this is going to be an initially rapid-acting IV lorazepam or Ativan or Valium. Newer anti-seizure meds that may be safer for older adults because they have fewer effects on the cognitive function and less drug interactions include things like Neurontin, Lamictal, Trileptal, and Keppra. Some research has shown the effectiveness of a ketogenic diet to helping control seizures. This would be a diet that's high in fat and low in carbohydrates, as the ketones pass into the brain and replace glucose as the energy source. The biofeedback to control seizures teaches the patient to maintain a certain brainwave frequency. For our nursing assessment, we want to assess the cerebellar function by observing arm swinging gait, as well as the finger to nose test. Patients with motor neuron lesions will have flaccidity of the lower extremities, such as with a spinal injury. We may also use things like an EEG to assess the electrical activity of the brain, and perform the Romberg test to assess for risk of falls. In the case of a Romberg test, the patient would stand up straight with their heels together. Then you'd have them close their eyes to see if they're able to still maintain their balance. Precipitating factors of a seizure include things like metabolic acidosis or alkalosis, hyperkalemia, hypoglycemia, dehydration, and water intoxication. They may also have symptoms like a bitten tongue, soft tissue damage, and cyanosis, abnormal respiratory rates, apnea, absent or abnormal breath sounds, and even airway occlusion. Another helpful strategy is seizure response dogs. Seizure response dogs receive special training to assist those in distress. Say their owner's having a seizure, they can go find help. They can also pull away objects that pose a danger, carry information about their handler for emergency response teams, and provide all around emotional support. Let's talk about multiple sclerosis. Multiple sclerosis is a chronic, progressive, degenerative disorder of the central nervous system. It's characterized by disseminated demyelination of nerve fibers to the brain and spinal cord, as we've got a picture demonstrating there at the bottom of the slide, of that myelin sheath being worn away off of the nervous system. There are up to 400,000 Americans affected, and it's more prevalent in temperate climates. Researchers suspect that exposure to some environmental agent before puberty may predispose a person to develop multiple sclerosis later in life. There are three pathologic processes that characterize multiple sclerosis: chronic inflammation, demyelination, and gliosis or scarring of the central nervous system. The primary condition is an autoimmune process driven by activated T cells. And here in figure 58-2 from the text, we have that pathogenesis of multiple sclerosis. In figure A, we have a normal nerve cell with that myelin sheath intact. In figure B, we have a normal axon. In figure C, we have that myelin beginning to break down. And then finally in D, that myelin's totally disrupted and the axon is not functioning. Clinical manifestations include the onset of the disease that is often insidious and gradual. Big symptoms occur periodically over months or years. Though not enough to seek medical attention, the disease is diagnosed long after onset of the first symptoms. These early symptoms may include things like blurred or double vision, red-green color distortion, or blindness in one eye. The treatment of relapsing forms of multiple sclerosis are immunomodulatory agents with anti-inflammatory properties. Or you may have drugs that prevent lymphocytes from reaching the CNS and causing the damage. For more active and aggressive forms of multiple sclerosis, you may have drugs like Tysabri, Lemtrada, or Ocrevus. Corticosteroids such as prednisone may also be helpful in treating acute exacerbations. They work to reduce edema and the acute inflammation at the site of demyelination. Exercise will also play a key role in treatment, as it decreases spasticity, increases coordination, and retrains unaffected muscles to act in place of the impaired ones. During acute exacerbations, we want to prevent complications of immobility. Also, focus teaching on building general resistance to the illness, such as avoiding fatigue, avoiding extremes of hot and cold, as well as exposure to infection. Infection control, especially, is going to be a top priority. Let's talk about Parkinson's disease. Parkinson's is a chronic, progressive neurodegenerative disorder characterized by bradykinesia, rigidity, tremor at rest, and gait changes. It affects up to 1 million Americans, and the incidence increases with age, as 4% are diagnosed before age 50. Men are 1.5 times more likely to have Parkinson's disease than women. The exact cause of Parkinson's disease is unknown. It's possibly a result of a complex interplay between environmental factors and the person's genetic makeup. Family history accounts in 15% of cases, and the risks increased by well water, pesticides, herbicides, industrial chemicals, wood pulp mills, and rural residents. Lack of dopamine may also play another major role, as the degeneration of these dopamine producing neurons within the substantia nigra of the midbrain. They disrupt the dopamine acetylcholine balance in the basal ganglia. These are essential for normal functioning of an extrapyramidal motor system. Lewy bodies also play a key role. And these are unusual clumps of protein that are found in the brains of patients with Parkinson's disease. It has an unknown cause, though the presence indicates abnormal brain functioning and eventually leads to Lewy body dementia. Keep in mind, the onset is gradual and insidious with ongoing progression. They also have the acronym TRAP to help remember the classic manifestations. These would be tremors, rigidity, akinesia, and postural instability. In the beginning stages, it would manifest as a mild tremor, slight limp, and decreased arm swing. While in the later stages, it progresses to a shuffling, propulsive gait with the arms flexed, and a loss of postural reflexes. The patient may also experience hypokinetic dysarthria, speech abnormalities. A tremor is often the first sign. Though initially minimal, it can begin by affecting their handwriting, and it's aggravated by things like emotional stress and increased concentration. It may also manifest as a pill rolling hand tremor, diaphragm, tongue, lips, and jaws that could also be involved. An essential tremor is not associated with Parkinson's disease, and it occurs during voluntary movement, has more rapid frequency, and has a familial disposition. Parkinson's disease will also be characterized by rigidity, and this means an increased resistance to passive motion when the limbs are moved through their range of motion exercises. You may also see cogwheel rigidity, which has a jerky quality, like intermittent catches within the passive movement of a joint. Other clinical manifestations include akinesia, or the absence or loss of control of voluntary muscle movements. This is not to be confused with bradykinesia, which is a slowness of movement, and this is particularly evident in the loss of automatic movements. From figure 58-9 in the textbook, we have the characteristic appearance of a patient with Parkinson's disease. Notice the forward tilt of the posture, the blank facial expression, slow, monotonous, slurred speech, tremor, and a short shuffling gait. Other complications of Parkinson's include dysphagia that may result in malnutrition or even that aspiration pneumonia. The general debilitation may lead to pneumonia, UTIs, and skin breakdown, as well as orthostatic hypotension being another major concern, as it could increase the risk for falls and injuries in a patient that may already have impaired coordination. The go-to drug therapy is levodopa with carbidopa, and is the primary treatment. Levodopa is the precursor of dopamine and can cross the blood-brain barrier and is converted to dopamine within the basal ganglia. Carbidopa, on the other hand, inhibits an enzyme that breaks down levodopa before it reaches the brain. Other options may be amantadine that increases dopamine release while blocking its reuptake, anticholinergics to decrease the activity, and MAOB inhibitors that both increase the levels of dopamine while prolonging the half-life of levodopa. Other options may be drugs like Exelon or Aricept that are used to treat dementia, and amitriptyline that may be useful in helping to treat the depression. The use of only one drug is preferred to help prevent polypharmacy, as this has fewer side effects and the dosages are easier to adjust. Combination therapy is often required, though, as Parkinson's disease results in excessive dopaminergic drugs that can lead to paradoxic intoxication. Here on figure 58-10, we have a deep brain simulator. This involves placing an electrode in the thalamus, globus pallidus, or subthalamic nucleus, and is connecting it to a generator placed in the upper chest, like a pacemaker. That deep brain stimulator can be used to treat tremors and uncontrolled movements of Parkinson's disease. The electrodes are surgically placed in the brain and connected to a neurotransmitter like device in the chest. Ablation surgery may also be considered, as this is used to locate, target, and destroy the area of the brain affected by Parkinson's disease. This destroys the tissue that produces abnormal chemicals or electrical impulses, leading to tremors or other symptoms. Another option may be the transplantation of fetal neural tissue into the basal ganglia. This provides dopamine producing cells into the brains of these patients, and research and clinical trials in this method are still ongoing. For nutritional therapy would involve malnutrition and constipation that can be serious consequences. Patients with dysphagia and bradykinesia need appetizing foods that are easy to chew and swallow, and also provide high enough fiber and fruit content. For nutritional therapy, these patients should be eating 6 small meals a day that is less tiring than eating 3 large meals per day. You also want to make sure to provide ample time so that they avoid frustration and have time to eat. Levodopa absorption can be impaired by protein and vitamin B6 ingestion, just something to keep in mind. For nursing implementation, we want to work to promote these patients' independence. Things like getting out of a chair by using the arms and placing the back legs on small blocks, removing rugs and excess furniture that could form a tripping hazard, simplifying clothing from buttons and hooks, using elevated toilet seats, and using an ottoman to elevate the legs. And finally, I've got a good wrap up slide here at the end. I know we talked a lot to help differentiate between the types of seizures, a tonic-clonic versus absence versus myoclonic versus focal. Also differentiating the different types of headaches and things to keep in mind for nervous system assessments. But anyways, that's all I got for this chapter. I'll see you in the next slides.